colleagues. Today, my topic is sudden cardiac death, heart failure, to predict or not. It's a very interesting question. Do we really have to predict the sudden cardiac death in heart failure? Yes, of course we do. It's not just a fortune telling. It's much more than that, because many people with heart failure die suddenly. Almost 15% of the stable heart failure patients have sudden cardiac death in 3 years. So it's crucial to predict the sudden cardiac death in this patient population. Why? Because we have miracle treatment tools like ICDs, as you see here. ICDs save life. So we have to predict the sudden cardiac death in this patient population. But how? The ICDs, as I told you, these are the cornerstone treatment in sudden cardiac death, and everything started with the secondary prevention trials. We can see here the three main cornerstone studies related with the sudden cardiac death, and ICDs prove the efficiency of their self in this patient population by reducing the arrhythmic deaths, also the total mortality significantly. If you look at this, especially the benefit of the ICDs was significant in heart failure patients, in the patients who has reduced ejection fraction. The patients who has the sudden cardiac death, the cardiac arrest survivors, you can see here they have a very high incidence of sudden cardiac death. And you can see that these three main studies here. The patient group we are talking about, the heart failure patient with reduced ejection fraction, are less incidence than these cardiac arrest survivors. But most importantly, I have to say, the annual event rate of these patients are 2 times more than the cardiac arrest survivors. So primary prevention in this patient group is crucial. Then we started to investigate the effectiveness of the ICDs in this patient group, and the trials conducted in the beginning of the 2000s, and we realized that the ICDs were effective also in primary prevention. You can see the MedicReS, MEDIC2, and sudden cardiac death heart failure study, and this is the study investigate the effectiveness of the ICDs on ischemic and non-ischemic patients, and also primary prevention also investigated in dilated cardiomyopathy patient in non-ischemic patient group. Although we have some concerns about in this patient group, the prevention, we started to implant ICDs for many years, more than a decade, by heart, because the guidelines used to say that we had 2 parameters, 2 risk factors to decide the ICD implantation. If the patient had heart failure and the ejection fraction was less than 35%, and if they were symptomatic, if their functional class was more than 2, New York Heart Association class 2, ICD was indicated in heart failure patients for both ischemic and non-ischemic cardiomyopathy patients. So as I told you, we had some concerns, but we used to implant ICDs by heart until the Danish Trial. Danish Trial increased the volume of the patient who had some concerns, especially in non-ischemic patient. It was a very big data, big trial conducted on non-ischemic cardiomyopathy patients who had elevated BNP levels. In this trial, what we have seen is, of course, ICDs were reducing the sudden cardiac death rates significantly, because the ICD do that, but the total mortality and cardiovascular death was not reducing. So we started to talk about the indications and patient selection, and also get very important lessons from the Danish trial. First of all, we realized the importance of the optimal medical treatment on heart failure. What has changed in 2 decades? First of all, the sudden cardiac death was very related with the optimal medical treatment. The sudden cardiac death heart failure trial, patients, only 70% of the patients used to get beta blockers, and only 20% used to have MRA. And in Danish trial, almost all patients had beta blockers, and significant amount of the patients were able to get aldosterone antagonists. I like this figure. It shows us the timeline of the treatments and how the sudden cardiac death decreased by the development of the medical treatment of the heart failure. So in the beginning, we used to have ACE inhibitors, and then beta blockers came. And each development of a new pharmacologic agent started to decrease the baseline sudden cardiac death risk. So optimal medical treatment is very important. You can see here a step-wise reducing of the sudden cardiac death and the annual total mortality. In a patient with heart failure without any treatment, the annual mortality is around 20%, and sudden cardiac death risk is around 9%. With the ACE inhibitors, beta blockers, aldosterone antagonists, all reduces the total mortality and also the sudden death. The reduction in total mortality is more than sudden cardiac death. ICD, you can see, until the ICD, this is only 3 agents. Guideline directed medical therapy reduces the total mortality to 7% and sudden cardiac death 3.5. And ICDs put a little bit benefit on this medical therapy, which is also important and significant in many cases. But these figures emphasize the importance of the medical treatment. What has changed also in ICD trial patients group in this timeline, you can see the overall risk and also the sudden cardiac death risk is reduced by time. You can see it in the ICD study patients characteristics. Also, the total mortality risk is reduced by time. That causes that the rate of the patients who are unresponsive to ICD increased, and that means we nowadays we need to implant more ICDs to get benefit than the beginning. So number need to treat significantly increased by time. It, of course, related to the patient populations, also the risk stratification, the mass immediate first MedicReS trials, we used to do EP studies, and we used to only conduct the very high risk patients who has sudden cardiac death. So second lessons from the Danish trial, it's also shows us the benefits of the CRTs in non-ischemic DCM patients. More than half of the patients received CRTs. And also, we know it's very useful tool with treatment strategy in this patient group, and it has the same impression with the optimal medical therapy. I think most important thing is the patient selection, because not every ICDs did not fail in every patient group. ICD provided some benefits, significant mortality reduction in young patients because they have more risk per year, and also the patient who has less BNP levels received benefit by ICD therapy. Patient with advanced heart failure does not have benefit, or has less benefit than the mildly or moderate heart failure patients. This graph explains what this graph shows us what I explained. This graph shows us what I explained. There are two curves. Green one is the sudden cardiac death, and the red one is the all-cause mortality. By reducing the ejection fraction, both risk of sudden cardiac death and also all-cause mortality increases. And you see here, the area between curves started to increase after 30% ejection fraction. Patient A, let's say, has sudden cardiac death and also all-cause mortality risk. But when the ejection fraction is 15, patient B, let's say, has also had sudden cardiac death, but the risk of non-sudden cardiac death or all-cause mortality is much more higher than the sudden cardiac death. So the patient A may get more benefit than the patient B with ICDs. The proportional risk of sudden cardiac death is higher in patient A. So the question is not to predict the ICD or sudden cardiac death or not. I think the question is predicting sudden cardiac death, or do we have to predict the patient who have the ICD benefit more? Predicting the ICD benefit, we have two questions. At what level of proportional sudden cardiac risk is an ICD likely to be beneficial? We have to figure out that patient. And at what level of overall mortality risk is the proportional risk of sudden cardiac death so low that an ICD is no longer beneficial? These are very old, elderly, fragile patients. For realize that, or to predict the patient who will get the benefit or not, many computer models are evaluated, investigated, and Seattle heart failure model is one of them. So you can see it evaluates the non-sudden death risks like older age, digoxin use, comorbidities, and sudden death risks, which is better health conditioned patients with lower ejection fraction. How does it work? Simply, you can go to the internet site, as I mentioned below, and you can enter the data characteristics of the patients. You can get here, as you see, the 5-year mortality curve, survival curve, sorry. And for example, I put as here a 65-year-old male patient with New York Heart Class 2-3, ejection fraction 30. This patient, so you can see with this program, what has changed with the therapies. So I didn't change anything with the characteristics of the patient. I put the guideline directed therapy, ACE inhibitors, aldosterone blockers, and beta blockers, and you can see how it changed the survival. And if we add ICD on this therapy, you can see the difference on the survival curve. So it's also shows us the importance of the optimal medical therapy in heart failure patients. So what I'm trying to say is heart failure is a progressive disease. So it goes, patients with mild heart failure goes to the advanced heart failure road. Some of them has more risks of sudden cardiac death, who has fibrosis, autonomic dysfunction, genetic susceptibility. These are prone to have sudden cardiac death. And the one who has comorbidities, older age, they have the higher risk of non-sudden death. So for that, we need better techniques to improve risk stratification. Currently, the current paradigm, we have only 2 risk factors to decide ICD implantation: functional capacity and ejection fraction. But we know today there are many other techniques we can realize and decide the risk of non-sudden death, like comorbidities clinically, and we can use the biomarkers as we saw in the Danish trial. If we have very severe heart failure, patient doesn't get benefit. Also, we can use some other imaging tools to decide the underlying diseases, which like fibrosis, which has a significant impact on ventricular arrhythmias. Most of the ventricular arrhythmias are reentrant arrhythmias, as we all know, and the fibrosis, scar tissue is the reason. So if we can see it, like MRI, so we can decide if the patient has the risk of ventricular arrhythmias more than the simple ejection fraction. I like this meta-analysis. Maybe it's not suitable for the MedicReS, but this is a meta-analysis of 29 studies evaluate the association of the presence of the scar and the sudden cardiac death. In all these studies, if you look, if patients have a scar, late gadolinium enhancement, they have more arrhythmic events. It's true for our patient group we are discussing today, also for the patient who has ejection fraction more than 35%, which is not represented in guidelines, as you see here. So, in this group, we have to, shows us the importance of the need of the better risk stratification tools. And ICD prevention is also benefit in patients with the scar because it's related with the mechanism. Another good example, these are the study conducted on CRT patients. And here, the mid-wall fibrosis were were investigated, the role of the fibrosis on CRT patients. If you look at here, so if the patient has the fibrosis, the total mortality risk is higher, and also the arrhythmic event rates are significantly more in the patient with fibrosis than the one who don't have. Also, we can see evaluate, assess the benefits of the ICD. So this is as I told you, these are the CRT implanted patients, and if the patient has mid-wall fibrosis, as here, the ICDs put benefits on this patient group. But if the patient doesn't have any scar in the ventricle, implanting ICD doesn't make sense. So we need better risk stratification tools than the previous. Until now, I try to tell the importance of the risk stratification and the risk stratification tools. Another reason why we fail in this patient group, particularly in non-ischemic patient group, we actually don't make the correct diagnosis. DCM, non-ischemic dilated cardiomyopathy, is a basket. We all put different patient groups, different etiologies in it. So we have many different etiologies, so which has different risk of arrhythmias. For example, patients with toxic overload or peripartum, they have arrhythmic risk, of course, but even their ejection fraction don't improve. The overall risk is very stable. But in genetic cardiomyopathies, it's a progressive disease. They are progressive disease, and the risk is always increased by time. So these young people, even their ejection fraction is normal, they are prone to have more sudden cardiac death risk than the other non-ischemic patients. So it's important to realize which patient has which etiology. It's a good example, again, genetic analysis of more than 400 patients with dilated cardiomyopathy. And if the patient has a mutation, the probability of the event-free survival is much more less than the patient who doesn't have any mutation. And also, in specific groups, the prognosis is very poor, like lamin A or phospholamban mutations. So the etiology and pathogenesis, understanding the etiology and pathogenesis of each individual patients can guide us to decide implantation ICDs. This is a good example from the 2019 HRS expert consensus. So it is different than the usual indication. So for a couple of recent years, we implant ICDs for these patients who has malign mutations like phospholamban, lamin A mutations, who has ejection fraction less than 45%. So how can we predict the sudden cardiac death better? New risk stratification parameters beyond the ejection fraction and functional capacity is obviously needed. Disease-specific risk factors, as I mentioned, is very important. We have to diagnose better and find the specific risk factors related with this underlying disease, and also the thresholds. And after the finding these risk factors and thresholds, this last 2 decades shows us the importance of updating the validity of the risk factors and the efficacy of the treatment with each new heart failure treatment. So that the heart failure treatment in pharmacology way, it's tremendously emerging. Every in 2-3 years, we learn new pharmacologic agents. We have to prove that the tools we use for sudden cardiac death is effective as it before. This is, I think, very important. How can we increase the benefit of the ICDs? It's very important. So the ICD we know today doesn't have everyone, and sometimes it's not good. Sudden cardiac death is better than suffering for the from the heart failure. So patient-tailored risk assessment again is important. We need better differential diagnosis to decide ICD implantation, understand the pathogenesis, and treatment based on this pathogenesis and differential diagnosis is important to increase the benefit of ICDs. Thank you very much for your consideration.